Our next panelist is Julie Goldstein Grummett. She's a clinical psychologist and public health specialist. She's the director of health and behavioral health initiatives for SPRC. We're happy to have you, Julie. Thanks.
So good morning. My name is Julie Goldstein Grummett. I'm the Director of Health and Behavioral Health Initiatives at the federally funded Suicide Prevention Resource Center, and I'm the Director of the Zero Suicide Institute at EDC. And we provide training and consultation to healthcare systems adopting and sustaining zero suicide. And I understand you've already had a lot of conversation over the last day or two about zero suicide. I'm sorry I had to miss the conference till now, but from the brief conversation that I've heard so far, it's been incredibly productive. So thank you for having me here. My role really focuses on embedding evidence-based suicide care practices into healthcare systems, whether that's zero suicide or other types of best practices. But what you've learned, it appears over these last couple of days, is that there are many resources now available for healthcare systems and providers to use that are effective and comprehensive, that directly target people at risk for suicide. And one of the biggest roadblocks that I see in suicide prevention is the lack of awareness that these resources exist. Despite the fact that the evidence has emerged, safety planning, screening, treatments like dialectical behavior therapy, cognitive therapy for suicide prevention, follow-up during times of care transitions. Despite the fact that the evidence exists to use these are vastly underutilized in healthcare systems. Very few healthcare systems employ these practices. I'm often stunned that we're not getting more phone calls as the nation's resource center from primary care practices. We know depression is one of the leading issues that people come into their primary care physician to talk about, and yet, frankly, they rarely reach out and say, "What do you got for me?" And please partner with us. And we do a lot of reach out to them, but I'm often stunned that it's really us leading this, and hope that roadblock begins to diminish. I heard this morning people talk about how healthcare providers are not required to learn about suicide-specific treatment practices in graduate school. I'm a psychologist. I happen to have an interest in suicide prevention, so that's what my master's and dissertation were on, but I was the only one in my year who had that strong interest, so I pursued it very directly. I hear a lot about people, I think Mike mentioned people have been in practice now for 20 years, continuing education requirements and other things are not required except for in a couple of states. And yet we send our loved ones to get care by providers who we expect that are going to be well-trained and competent and confident, and the workforce isn't. We have many surveys to attest to the fact that the workforce does not feel comfortable and confident, and we don't tolerate that in medical care. Right? We would never send our loved ones to a surgeon who said, I didn't really have any training, but I'm going to try my best. But we do that in behavioral health every day. We send our loved ones to providers who we think are well-trained, but really are doing their best. And they absolutely are incredibly caring individuals, but they don't have the skills. They haven't been trained in suicide-specific practices. Zero suicide would be the bullseye, right? We'd really love that to be adopted by all of healthcare. We believe it really is transformative in the healthcare systems who have adopted it. But the National Action Alliance for Suicide Prevention earlier this year released recommended standard care practices that healthcare providers could adopt. We'd love to see, one improvement that we'd love to see is more national organizations endorse and distribute these standard care practices, and that healthcare providers would be familiar with these practices. Nadine asked us to respond to how healthcare could be better partners to reduce suicide. So I think that healthcare systems could be better partners by tracking and critically examining and sharing their data on rates of suicide for those whom they care for, and then striving to improve and do better. There's no obligation for healthcare systems to share their data, so there's really no benchmarks you don't really know how well you're doing. I think this happens kind of very informally. Healthcare systems share, but this isn't very transparent. They're very concerned, obviously, with saying what % of their patients have died by suicide. And yet without that, we'll never really know where we're making traction or how to learn from systems that are doing tremendously great care. I think it's emerging through Zero Suicide. The healthcare systems are starting to share their outcomes, starting to publish on that. But we're really at the beginning of that, and we can't take 15 or 20 years to get further down the road. Another roadblock, and Marcus talked a little bit about it, is the challenge we face in reaching individuals who are not seen in healthcare. The recent CDC report finds that more than half the people who die by suicide do not have a mental health diagnosis. And these data reveal that there are many shared characteristics by those who die by suicide without a known mental health diagnosis, as well as men in the middle years, sort of 35 to 64, who we know are at increased risk for suicide. They have increased alcohol use, relationship or intimate partner violence, domestic violence, legal problems, financial problems, past military experience, trouble holding down a job. This is a very wide breadth and scope, and it could feel very overwhelming. Certainly it's a roadblock in one way to look at it, where to begin with so many shared risk factors. And yet, I think it really raises the opportunity for new and non-traditional partners. I think we have to look outside of healthcare. Healthcare is one solution that we really need to embrace and fortify, but we also have to be much more creative and think about paraprofessionals and peers and other types of community-based efforts. There are good examples of this emerging, but I think we really need to embrace those to reach people in culturally appropriate ways. If they're not going to come into healthcare, then we need to find ways to reach them where they are more comfortable seeking care. And despite some of the challenges that I've articulated, I do think that hope prevails. When we had the recent suicide deaths of Anthony Bourdain and Kate Spade, I think the media there were fewer stories that were focused on sort of their graphic details and their traumatic lives and the conclusions that they needed to die by suicide. There were many more stories that focused on hope and help and recovery and where to find that help, and how many people who have thoughts of suicide do not go on to kill themselves and do go on to live very meaningful, quality lives. And I think the media is really beginning to get it right. I think this way of communicating about suicide certainly offers hope in ways that those who are at risk for suicide can hopefully begin to feel less judged by others, less ashamed, come forward with their stories about their suicide experiences or good experiences that they've had, and begin to offer that the healthcare community or some community-based resources are available. I think we're beginning to move away from just kind of awareness building to really empowering the public to know what to do, to know where to get help, to tell their story. And the more that we do that and break down these barriers, the more likely we are to reduce suicide in this country as people feel comfortable, right? If my daughter needs a referral for a dentist, I throw up on Facebook, hey, who's got a good dentist out there for a 10-year-old? But if my same daughter needed a referral to a psychiatrist, I might think twice. I don't, but I think many people do. And I think that's incredibly unfortunate, because we have to rely on those around us to tell us where, to comfort us during these times that are very difficult, and to help us to find services that are available, and to have that same comfort on the mental health side, particularly with serious mental illness and suicide, that we do in the medical world. With regard to how might we increase investments and effort in suicide prevention, I think it has to be both downstream and upstream. It has to be a marriage of public health and mental health. I think downstream efforts are things like Zero Suicide, the use of robust electronic health records that can really capture the work that healthcare systems are doing, well-trained staff, the ability to collect data, examine outcomes, share that data. We need to invest in crisis care. We need to have 24/7 crisis services available, and psychiatric emergency rooms. The availability of these might reduce the burden in emergency rooms and provide better, more quality, more timely care to people with mental health needs. Upstream means that we need to really tackle the risk factors that are shared for many of the same challenges people face: economic despair, lack of connectedness, exposure to trauma. We need to work much more closely with the nonprofits, the national organizations, the organizations that work to address these types of issues. We work in silos frequently, and we can't expect that things are going to change if we're in silos. And finally, I think technology will really continue to emerge as a place that we can rely on. We have apps for safety planning. We have apps to push out messages of thought and hope and caring for our loved ones. We have things like predictive analytics that are being used in the VA and elsewhere to help really target who might be at greater risk. If they're not coming into care, we need to proactively reach out to them. And as I said, things like Facebook, where it's not just about, posting pictures of your family, but posting the opportunity for resources, including scientists who are looking now at algorithms to determine what is the language that people who have made suicide attempts or died by suicide used in their Facebook posts. So I think there's a whole field still available to us with regard to technology that I imagine will continue to emerge.
Thank you. And I know since Marcus answered the final question with his comments, if you want to do that too, which has to do with your short-term and long-term recommendation.
My short-term recommendation would really be using data in wherever system you are. If you're in a state, if you're in a healthcare system, community, that you need to know who in your system is dying by suicide and determine interventions to target the highest risk populations, including the fact that these have to be comprehensive approaches. We can't use one single intervention or focus exclusively on schools if it's middle-aged men in the community who are dying. So in the short term, I really hope that people will use data and share their data. In the longer term, I really do think it's collaborating across these different types of challenges that we face now in society, whether it's opioid misuse, whether it is domestic violence, trauma, and early childhood, and really collaborate more, whether it's grant opportunities that we really begin to reach out to one another and partner and collaborate, publish together, that we really see these as kind of public health issues, that by collaborating, we will have much greater impact much faster, rather than each of these challenges operating separately and leaving it to kind of individuals and communities to make meaning of picking from each of these various entities.
Great, thank you very much. Great comments.